a little bit of what I wanted to talk about is after treatment and what happens when patients at that time want to know about their infertility risk, and also they want to know, well, am I infertile or not? So we talk about that as the fertility status assessment. We think about what puts you at risk for infertility. There's certain kinds of chemotherapy, not all chemotherapy, but alkylating agents, heavy metal chemotherapy, radiation, of course, to the gonad, cranial radiation above 30 gray. So that's not permanent infertility because the gonad itself is not damaged, but now you don't have proper LH and FSH signaling, so they can experience infertility. Sometimes you can override this by using a GnRH pump and those kind of things, but from a patient perspective, they might report and experience infertility. Certain surgeries, certainly removal of one gonad will put you at risk, although you still have one gonad, so it's a low level of risk. Retroperitoneal lymph node dissection, remember that'll give you retrograde ejaculation, but sperm can be recovered from the urine. Bone marrow transplant puts you at high risk for infertility. So what can we do about that? And this is all a little bit of a review, but for pubertal females, so those older than 14 and menarchal, we can offer ovarian stimulation with oocyte harvest. So that's the traditional fertility preservation that we think about in females. The tricky part of it is that it takes 2 to 3 weeks. It requires serial vaginal ultrasounds to assess follicular growth. Lots of shots at home and a lot of blood draw. So it's labor intensive, but it's the more traditional kind of fertility preservation. As of December of last year, ovarian tissue cryopreservation is no longer experimental. And this is basically the removal in high-risk girls, the removal of a whole ovary. And you take cortical strips from it and then you freeze it. And the reason that it was moved off of having an experimental label is that there have been over 130 births from tissue that's been transplanted back into females when they were ready to become pregnant. For pubertal boys, older than 13 or more than 10 or 3, they can sperm bank, and this is pretty straightforward. If for some reason they can't, you can consider testicular biopsy for sperm retrieval. Prepubertal girls, the only option is the ovarian tissue cryopreservation I talked about previously, but to date, there's only been 1, maybe 2 births in that population. And some of it may be that these girls are still really young. I mean, they haven't reached the age where they're ready to start a family, but we really just don't have evidence in the literature that of how successful this is going to be. And in prepubertal boys, you can take a testicular tissue biopsy, which is about the size of a pencil eraser. And this is experimental, should be done without doubt under an IRB protocol. Currently, most places also feel that way about prepubertal girls. There has been 1 primate birth from a monkey in whom testicular tissue was harvested prepubertally and then transplanted back. And I think it's sort of interesting. The name of that baby was Grady, and it's an acronym, but I just think it's really interesting that it was Grady. Any questions about that?
Not yet.
Okay, I'll keep going. So this is actually hot off the press. So this is this is something that I led the charge on with a national, actually international group from the Pediatric Initiative Network of the Oncofertility Consortium. And the reason that we had about, I should know this, we had 26 people from 17 institutions weigh in about how they were describing level of risk based on exposure. And the reason we felt this was important was that people were using all kinds of different definitions. So it just made it very hard to compare literature, to counsel patients, or to counsel a patient should they move. Like if at one place they told you you were at low risk and then you move to another state and now you're at moderate risk, it just gets really confusing. So we all put our heads together. We did a literature search, and mainly through some evidence in the literature, a lot of expert opinion, this is now what we call the risk stratification grid, and this is for males. So you can see that at an alkylator dose, so if you, it's a cumulative cyclophosphamide equivalent dose, that's what CED stands for, at 4 grams per meter squared. If you're less than that, you're at minimally increased risk. So if you force me to put a percentage on that, I'd say maybe 20% chance of infertility. And actually the data from Dan Green's paper on semen analysis, I think it was really pretty close to that, because I think 81% of people below that had normospermia. So however, if you're above that, they bumped you to a high level of increased risk. So they sort of skipped that middle level. And I think part of that was driven by the fact that it is relatively easy to sperm bank, and we really wanted to encourage patients to do that if they were above 4 grams per meter squared. The next is bone marrow transplant. All forms of alkylator or TBI-based preparative regimens, even reduced intensity, are considered to place a patient at high risk for future infertility. Again, if you forced me to put a percentage on that, I would say probably greater than an 80% likelihood that they're going to experience infertility. Heavy metals are at a lower risk unless cisplatin in males is above 500 milligrams per meter squared. One thing to notice is that those are tiny doses of testicular radiation. So it doesn't take much radiation to render a patient infertile. We talked a little bit about the hypothalamus already, and then we have the surgery listed. Any questions about the male grid? Okay, I'll go on to the female. So the female grid's a little bit trickier because we have to, for alkylators and for ovarian radiation, there's a difference in whether you receive that treatment before puberty or after puberty. After puberty, you're more vulnerable, and as you get older after puberty. So an 8-year-old is going to be more tolerant than a 12-year-old who's in puberty. And the 12-year-old can tolerate more chemotherapy or radiation than the 18-year-old versus the 25-year-old or the 30-year-old. So, and the way you can sort of think about that is the prepubertal ovary is asleep. So if once it becomes pubertal and it's active, it's more likely to be damaged by alkylators and radiation. Why that doesn't happen in the males, I don't know, but we don't have evidence that the age at exposure plays as much of a role in males. That's also why we use depolupron. So depolupron takes a pubertal ovary and shuts it down. If you will, it sort of makes it prepubertal. That's why we talk that it may be beneficial. And the reason we use the may be term is that there's just not evidence in the literature in pediatric cancer survivors that this actually affects the rate of infertility. The reason that's so hard to do is infertility or fertility is a really long-term outcome. When you're talking about a 12-year-old, well, she might not try to become pregnant for another 10, 15, 20 years. So we won't know whether she's going to experience infertility until that time. So this is a challenging area to do research. And so sometimes we have to use surrogates like ovarian failure or elevated FSH instead of true infertility. Okay, so here you see the cut points for the alkylator exposure, and the prepubertal girl can, if she's less than 8, it's minimally increased risk. Whereas if she's pubertal, the cut point is 4 grams per meter squared. And likewise, the upper limits, high level of risk at above 12 for the prepubertal and above 8 for the pubertal. Heavy metals are thought to be minimally, to render or cause them to have minimally increased risk. Bone marrow transplant, a high level. You can see the cut points for radiation, 10 for pubertal and 15 for prepubertal. Again, prepubertal can tolerate more. And then the hypothalamic exposure. Any questions on that? This is what, how, when we're coming to do a fertility consult, that's why we're sort of, it's like, can you tell us the protocol? Because we're going to go through and calculate, like we're going to convert all of the alkylators to cyclophosphamide so we can figure out where we're putting them on this grid so we can advise them about what kind of fertility preservation intervention they should consider.
The Lupron, people always discuss whether it's like good birth control or not. And then the other question is how it affects bone health and how that changes whether you're on it for a long time or not, and whether you're on agestin or not.
Okay, so you were talking about Depolupron and whether it affects bone health and about contraception. Let me start there. So if a patient is of age and they're sexually active, Depolupron does not provide contraception. So and that's something that we always have to be sure that we talk to them about, or even if we go in and we're talking to a patient about fertility preservation, they whether they're on Depolupron or not, they may, just hearing the word infertility, I think it often converts to, okay, I don't have to use birth control. So I think in any AYA-aged individual, it's important to say that, yes, you need full contraception. In terms of bone health, I think, is an important issue. And what I think that probably this relatively short term of hypogonadism, which is basically what we're doing with Depolupron, is perhaps not too detrimental, as long as we're really being sure that they maintain adequate calcium and vitamin D, which I would say most patients are not. So I think as part of the Depolupron conversation, it's not a bad idea to talk about, RDA amounts of calcium and vitamin D. Agestin. So, the way that agestin comes, because I think that we all have a little bit, you might find that some of us have a little bit different thoughts about agestin. So agestin, the reason some people use agestin more is because it alleviates the side effects of being menopausal. So we are adding back agestin so that we won't have as much trouble with hot flashes and those type things. However, the other side of sort of the hormone replacement while on Lupron discussion would be that we sometimes have to balance that against the thrombophilic effects of female hormones. Now, agestin is a progestational agent, so it's not thought to be as thrombotic inducing as estrogen. So we would be really worried about using birth control pills or estrogen, and if we're worried about clotting in a newly diagnosed oncology patient. So agestin's better than estrogen. My bias is that sometimes some people don't really get hot flashes or don't complain of them that much with the Depolupron. It's a very individual thing, just like some people suffer from menopause more than others. An option could be that, you sort of monitor and see if they develop symptoms of hot flashes and then add in the agestin. So that would be one approach. And there is some data. The third thing is that there may be some data that agestin may be beneficial to bone health. But I think the first line is the calcium and vitamin D. Does that answer your questions? Or is there some more?
No, that's all of them. Thank you.
Okay. All right. So let's go to the next slide. So this is just a little bit of information so you can see how the fertility program has grown since we started. Back in 2014, we sort of started those Think Sperm boxes. In 2016, we actually developed a formal consult team. You could just email one address and somebody would respond to you. And with that, our consults, you can see, almost increased fourfold. And then we've had steady increase every year. And now we've added different kinds of consults. Like we're doing a whole lot of pre-BMT, non-onc pre-BMT consults. some RN-only consults. And last year we had still a 25% increase in volume. So one of the questions that we might consider is, what do we know about fertility and infertility in survivors of childhood and adolescent cancer? I think it's important to understand that infertility does not equal 1 minus fertility. So just because if you had a population and 70% were fertile, you can't say the other 30% were infertile, because maybe they weren't trying to become pregnant. Maybe they were in a relationship where, where you wouldn't expect a pregnancy. So I think a lot of people make that mistake and think that, well, the 30% that didn't get pregnant are therefore infertile. And they try to do comparison data with that. And it's just simply faulty thinking. Having said that, fertility data is easier to collect than infertility data, because fertility, well, you just count how many pregnancies there were. Infertility, people have to say, I tried to get pregnant for a year and I was unable to. One, that's self-reported data, and it is relatively difficult to collect. But when we look at female survivors compared to their siblings, they are 20% less likely to experience a pregnancy. And when they were asked to self-report infertility, they were 50% more likely to say that they were infertile. Again, I think this reflects that difference in who of the people that weren't pregnant were actually trying to become pregnant. And in males, almost 50% were less likely to have sired a pregnancy. And when we collected specific infertility data, male survivors were 260 times more likely to self-report infertility. This is data from St. Jude Life, which actually looked at survivors, and they looked, this is what they looked at: menses, FSH, and estradiol. And males, they looked at semen analysis, and then they looked at male hormone production failure. And they looked at patients who received alkylators or radiation. Then this is going to show you the number that are at risk, and how many said that they had premature ovarian insufficiency before they were evaluated in St. Jude Life, and it was 8%. That number went up to almost 12%, so a 50% increase after they actually had these labs done as part of their St. Jude Life assessment. For males, in terms of germ cell dysfunction or lack of ability to produce sperm, 2.7 up to 66%. And these are older survivors. And then for testosterone deficiency, 4% up to 11.5. So when I'm talking about rates of infertility overall in all survivors who got alkylators or radiation, I'm talking about 12% in females and 66% in males. That's why we really, really push to get those males to sperm bank. Also, it's so much easier to sperm bank than to harvest eggs. So this is really a missed opportunity if we aren't able to get those boys to bank. But what do survivors think? What do they actually, if you ask them, are you at risk for infertility, what would they say? So we actually there was an online survey completed by 92 survivors, and these survivors were aged 22 to 43 years. 82% reported they knew about their infertility risk. 75% recalled being told they were at risk for infertility, but 29% didn't believe it. I don't really, don't kind of know what to say about that. Although maybe denial is a strong thing, but it doesn't matter. That's their perception, and I think that's important. This is a study that actually I did through the Childhood Cancer Survivor Study, and we looked at 1,300 adult male survivors of childhood cancer, and we asked them about their perceptions of their risk for infertility. 36% of those who were not at risk, they didn't receive gonadotoxic treatment, reported that, 36% of those who did receive gonadotoxic treatment did not think they were at risk for infertility. So a third who were at risk said, no, I'm not at risk. Interestingly, a similar percentage who did not get that kind of treatment thought they were at risk for infertility. So this has a lot of implications. Those that are not at risk, that think they are, may not practice good birth control. those that are at risk but think they're not, there's all kinds of things around regret that they didn't sperm bank. Maybe they didn't really understand what was presented to them. So there's lots of room for misperceptions. Does age play a role in this? So this is another study that we did, and it was 48 female survivors and their parents, and 41 parents were asked about whether they were at risk. 58% of the survivors thought that they were at risk, and 82% of parents thought that their daughters were at risk. So these are people who are at risk. And it does differ by age. Look at the percentages that go up as the girls get older. And in truth, we've probably had additional conversations about the gonadal function as they've gotten older. And the parents, you know, are go up a little bit, but are still at a pretty high percentage. I think that this is another interesting study. So this is newly diagnosed adolescent males and their parents report what their oncologist told them. So this is information gathered near the time of diagnosis, at least within a month. So the oncologist said that they told this group of patients that that of this population, none were not at risk, a third were at low risk, and 41% were at moderate and 25% at high risk. What the adolescents heard was that 5% reported they were not at risk, 38 low, 50 moderate, and 7% high risk. So a significant decrease where the oncologists think they're telling a population they're at high risk, the population's not hearing it. And for the parent report, also this is interesting, where the oncologist didn't say anybody was told they were not at risk at all. 5% of adolescents and 1% of parents thought that they did say they were not at risk. And then you can see again, even with the parents, low, moderate, and high. But it isn't all consistent. Like, it's not necessarily that they were told moderate and they thought they were low. Some that were moderate thought they were high. So there's a lot of crossing. Over 60% of the adolescents reported their risk inaccurately, but there was 30% underreporting and 17% overreporting. And parents, about the same overall risk of inaccuracy, but 35% underreported, 23% overreported. And again, what we talked about, underreporting distress following treatment and regret or resentment for not pursuing fertility preservation, and overreporting unnecessary worry, impact on relationships, and unplanned pregnancies. And I think that when we talk to, one thing I should pause and say is that when adolescent, young adult survivors were asked, now that you're past your cancer diagnosis, what are your health concerns? Not being able to have children is in the top 3. Number 1 is, you know, can my cancer come back? Number 2, can I get another cancer? And number 3 is, can I have children? It's higher than, is my heart okay? Are my lungs okay? You know, so many other things. So fertility is a really important, disproportionately important in some ways, meaning that it just carries a lot of weight and it has a lot of significance to families. And I think we have to be sensitive to that. Any questions on that? Okay, good. So I wanted to show you, because communication is such a challenge, I just want to run through a little grant that we did. It was with funding through CURE, and it was all aimed at trying to evaluate effectiveness of an evidence-based educational intervention in increasing survivors' knowledge of their personal risk for infertility. So we basically did a baseline survey in REDCap where we assessed their perceptions of their own risk for infertility and their concerns about possible infertility. Then the survivors, and these survivors are 18 and older, so 18, 19, 20, and some 21-year-olds. They had a parent-free, one-on-one, personalized educational intervention regarding their risk for infertility with an oncofertility provider. And this is only if they wanted to. So they were offered it, and if they didn't want to, then we were fine with that. And then we did a follow-up 1 month later with the same baseline questions and trying to understand their perceptions. And then we asked them about their preferences. How would they like to find out their risk for infertility? And also preference for timing of fertility status evaluation. So there are tests we can do in survivorship to find out, what does it look like that their chances of having children will be? And it's basically semen analysis in males. And we can do an AMH or antral follicle count in females. And we tried to make it really simple. Only 4 concepts that we were asking about. We wanted to know what their thoughts were about whether they're at risk for infertility, dichotomized to yes or no. Then we wanted to know what they thought their level of risk was. And it was the low level, the moderate, or the high, or none. We wanted to know whether they thought they had a limited number of years to have children compared to their peers. So in at-risk females, we know that they are at risk for an earlier menopause. Their window of time to have children may be narrowed. In males, if they are making sperm at the end of treatment, they'll continue to make sperm. So I tell them, if you're making sperm at the end of treatment, you'll make it when you're 20, when you're 30, when you're 40, when you're 50. So they don't have a limited number of years, because some girls, if they do have a limited number of years and they decide, oh, I'm done, I'm cured, I'm gonna go to college, I'm gonna go to Peace Corps for a couple years, and I'm gonna go to grad school, oh, maybe I want to go to med school, and I'm gonna keep putting all this off, the other important things come up, and then all of a sudden their window closes. And so it's important that they knew it could close so that they can incorporate that in their plans. And then our always last question, if you're sexually active with the opposite gender, do you need to use protection to prevent a pregnancy? So in phase 1, we started by doing this concept of plicit, which basically, it took me a long time to learn this, but basically I asked permission to have this conversation. And too many times I have gone in and said, okay, they're 18, it's time to have, the male health, female health discussion. But if a patient's not ready to hear it, then it's not the right time to have it. And so actually saying, hey, is this a good time? Sorry, phone's ringing. To have this discussion. And if they say yes, then we proceed to have the discussion. We went over what hormones tell us, the information about the window of fertility, their level of risk, and their need for contraception. And then this is also important. I will say that both the plicit model, and plicit is permission, limited information, specific suggestions, and intensive therapy, meaning we ask permission, we give them specific information about their risk. We give suggestions. If you'd like to know about your hormone production, we can get these hormones. If you'd like to know about your fertility status, we can set up a semen analysis. The intensive therapy has to do with if this is really upsetting to the family, that we offer psychology counseling to sort of process the information about risk for infertility. Teach back is where we have patients repeat back the 4 concepts. And I always say it's sort of like checking how well I communicated. Do you think, if I were to ask you, are you at risk for infertility, would you say yes or no? And then what would you say your level of risk is, low, moderate, or high? Do you need to use contraception? And do you have a limited window? So, and actually both plicit and teach back were taught to me by Brooke Shervin, who is the PhD researcher. And these were major turning points in how I try to communicate, for me, and how I try to communicate with patients. So we did a phase 1, we evaluated the effectiveness, and then we modified it for a phase 2. So these are the results from phase 1. So these are the 4 basic concepts. Are you at risk, yes or no? 65% thought they were at risk on their baseline survey. By the end of the educational session, these gray bars, everyone was at 100%, because if they didn't answer correctly, then I went over it again so that until they were able to get all the teach back responses correct. But a month later, they were back down to 76%. Their level of risk, 35, 100%, back down to 52%. Window of time to have or father a child, from 70% to 100%, then back down to 90. So this was the only significant improvement. And this is disheartening, but do you need to use protection to prevent a pregnancy? 50% said yes at baseline. All of them had that concept at the end of the discussion, but then 30% said they didn't need to use protection, which anyway, so then we went on to phase 2. So phase 2, we modified the educational intervention, and we developed this handout, which we personalized and gave to them. So remember, when they do their follow-up survey, it's an open book test. They can use this handout so that they have the correct information. So again, the grid was a little bit different a few years back, but we sort of talked about the grid. We talked about their level of risk. I went over their labs. I mean, I even tried to make it funny. Like, if you don't want one of these now, you have to use a condom. And then we would go, this is the teach back part. I even circled the right answers and then gave them this to take home. And these are the follow-up, the baseline and follow-up rates for phase 1 and phase 2. So infertility risk, yes or no, we already talked about this. It went from 68 to 92 with the handout. The risk level went from 39 to 87%. Window of time to father a child, it was already high and it stayed high. And protection to prevent a pregnancy went from 70 post to 81 post. But still, 1 in 5 patients don't think they need to use protection. So I think this is a thing that we have to continue to say every time, or to figure out different ways to communicate this where it's clearer. When we asked them whether this kind of discussion was helpful, no one said it wasn't helpful, but females thought, 2/3 of them thought it was helpful, where 1/3 of males thought it was very helpful, and the balance was slightly or moderately helpful. I think this isn't, we asked, would you have preferred your parents remain in the room for the infertility discussion? About 1/3 of girls said yes. Almost no boys said yes. So that's like 3%. And then when asked who should bring up the topic of infertility or the chance to have this discussion, very few survivors thought they should be the one to bring it up. So I think it's important. The takeaway points here are they aren't clear on their risk, and they are not comfortable being the one to bring up, oh, can we talk about infertility this visit? We asked them about testing for infertility, and you can see here that 50% of the females wanted further testing and 34% of the males said yes. There's a large percentage, and I don't know. But if we said if we could do it for free, that number went up to 71% of females and 66% of males. So what did we learn? That the majority of survivors would like to have a child one day. It was like 80 or 90%, a very high percentage, hope that they would be able to have a child one day. Survivors find opportunities to discuss their risk for future infertility helpful. Personalized information provided in a handout given to patients to take home improves knowledge of infertility risk. Patients' preferences need to be taken into account in planning an educational approach and may be impacted by gender. Clearer communication strategies around pregnancy prevention need to be developed. So what do we do? What do we do in the Aflac Cancer Center? Well, certainly at diagnosis, we have a chance to talk with them about fertility preservation. When they first come to survivor care, when we're going over their survivor health care plan, and we're outlining what kind of late effects they might be at risk for, gonadal dysfunction and infertility is listed on that. I may talk to them as part of their discussion around delayed puberty or failure to enter puberty. But this is an interesting thing. It's very family dependent. And I've had some parents just sort of look at me and shake their head and say, no, don't talk about that. We don't want to upset her or upset him. And so I sort of follow their lead. But some parents are very protective and don't want their kids to know this, and it's always tricky then, because like, when is the best time? Do we wait till they're 18 and they can make the decision about the conversations they want to have? It's it just has to be a very open dialogue. Then at age 18, we offer all survivors the female or male talk, and we utilize implicit teach back, take home handout, and we offer status assessment. And then again at transition to adult care, I will review the male and female handout, again, offer status assessment, and provide adult resources for follow-up. And in addition, anytime they want to talk about it and they bring it up, we're happy to have that discussion. So fertility status assessment in girls. This is a great curve. It's probably my favorite curve. It talks about when girls are born, they're born with a million eggs. And you lose eggs over time. And when you get down to 1,000, that's when menopause happens at about age 50. When you're exposed to radiation or chemo, actually I have arrows for all these, you have an abrupt drop in your egg pool, your primordial follicle pool. And now you're at this point, and you'll parallel this curve based on what your level of oocytes are. And this girl, you'll see she will hit menopause at about age 18. So this is called the Fatty-Gosden curve. And what I know is that when a patient comes to survivorship, I have this window of time that we might be able to harvest eggs before she goes into menopause. So in Survivor Clinic, we monitor labs and their best off hormone replacement therapy. FSH, which is the traditional ovarian lab that indicates menopause, is a late indicator. That means it stays normal, 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 and all of a sudden it's 40. And 40 is the level that we use to define premature ovarian insufficiency. FSH can be suppressed by high estradiol level and by birth control pills or hormone replacement therapy. AMH, anti-Mullerian hormone, reflects the primordial follicle pool. It's a blood test. It doesn't have to be drawn on a specific day of the menstrual cycle, and it's affected less by HRT. So we offer AMH tracking in girls, hoping that when it's low, we can identify this window when maybe we can harvest eggs. So we have a special clinic. It's called, so if you get an AMH and it's low, now you have diminished ovarian reserve. We have a special clinic at Eggleston that we offer once every other month, where the REI, Reproductive Endocrine Infertility Fellow, comes and we meet with patients. They do an abdominal antral follicle count. And we talked, it's like a mini infertility clinic consult. We talk about what is the process of ovarian stimulation, what does it look like if we try to harvest eggs, what are the specific procedures, and the cost, because this is expensive. This is like $10,000, not often covered by insurance. But if they're a cancer patient, we have ways of potentially getting that cost down to $2,000 or $3,000. And then we have this whole handout. We have all of the REI clinics that are in Atlanta that they may want to go to. So this is like a normal ovary, and the REIs talk about it like being a chocolate chip cookie, and each of the chocolate chips is a growing follicle in any given month. So when you go to a fertility clinic and you get fertility shots, what you're trying to do, instead of having one follicle grow and release an egg, you're trying to get them all to grow. And then when they're big enough, they actually do a transvaginal harvest. They put a transducer into the vagina. It has a needle that extends. And when these ovaries are stimulated, they fall beside the vagina, and they can actually go through the wall of the vagina into the ovary and aspirate, and they capture the eggs. So that's the process for oocyte harvest.
How long does that take? Like, how long do you?
How long does it take? 3 weeks. So it's, you know, in a perfect world, they'll tell you that they could do it in 10 days. I will tell you it pretty much takes 3 weeks when we try to do it when we're delaying chemotherapy. And it depends a little bit on how responsive the ovaries are. So remember, in these girls that have had gonadotoxic treatment, their ovaries are pretty less responsive. So sometimes they have to use higher drugs, and it may take a little bit longer. In truth, so you need to get 10 eggs. We tell the girls we need 10 eggs to have one pregnancy. And that has to do with, even in like older women, when they go to fertility treatments, these are sort of the numbers that they report. Because some of the eggs that are harvested are not healthy. Some don't survive freezing, some don't survive thawing, some don't survive fertilization, some don't grow. So we are pretty much saying you need 10 eggs, 8 to 10 eggs, to feel good that you're going to get one pregnancy from them. In our girls, before starting cancer treatment, I mean, it's easy to get 20 eggs out. We've even had one sickle cell girl before transplant that got 40 eggs out. When they do this imaging after treatment, sometimes we're seeing 3 to 5 follicles. And some girls will say, well, it's the only chance I have. I want to go ahead and harvest them. And some girls will go through several cycles to get their 10 eggs, which is a lot. And it's a lot of money. Fertility treatments are not cheap. And then in addition, there's the cost in 10 years when they want to thaw and fertilize those eggs and put them back in. It can be daunting. And what I try to tell patients is I feel like in 5 to 10 years, coverage for fertility treatments related to cancer therapy will be better covered by insurance, Medicaid, whatever. I mean, this is not your garden variety, infertility treatments in an older female, but this is like cancer treatment related infertility. So that's what I say.
Lillian, this is Summitri. Can you hear me?
Okay. Yeah.
I have a question. I've had a couple of teenage girls that I see in therapy who are like several years off, like post BMT, who have brought up questions, and parents have brought up questions about infertility and egg freezing. And I appreciated that that graph that you shared about their window of time. Because some of the concerns I've always heard is just like when they should do it or like how long they should wait. And so is the overall recommendation that like once they're in the teenage years that they should, if they're thinking about doing it, they should do it like sooner rather than later, or does it matter as long as they're within that window?
Yeah, no, that's a great question. So I think that if they think well, number one, for bone marrow transplant kids, Summitri, it's their AMH is undetectable. Okay, so like the sickle cell girls, it would surprise me if a girl after bone marrow transplant had a good AMH level. And remember, AMH reflects, let me take you back here. So AMH is going to reflect your pool, okay? So like in the sickle cell transplant girls, when I measure their AMH after treatment, it's undetectable. So there's a lot of controversy in the world about what does AMH actually tell you. So AMH, in truth, in the beginning, all it would tell you is whether you will respond to ovarian stimulation. And the reason being is that it's going to reflect this pool. Okay, so I hope I have enough time. So y'all tell me to stop talking if I need to stop talking. We're almost done anyways. But what I tell patients is that think of your follicle pool, which is what you were born with, as a bank account. Based on whether you have this bank account or this bank account, it will determine how many eggs you can put forward each month to grow. When your bank account starts to get really low, you can only put 5 eggs out. When your bank account is here and more healthy, you can put 10 eggs out per month. So AMH is going to tell me, is going to reflect your bank account, as does your antral follicle count. AMH is made by the growing follicles. So let's see where it was at. So these growing follicles are what are going to make AMH. So it's all a reflection of something. So if I see you and your AMH is really low, I'm going to start saying, in the best way that I can. And Summitri, I'd love for you to talk about the best way to communicate this, but it's really sort of like your bank account's already so low, we're not likely to be able to, we may have trouble getting enough eggs out, because I don't want to tell them they can't. Of course, I wouldn't do that, but I also want to set realistic expectations. So the higher your level of treatment, and if your AMH is low, then you have this window that's going to close. And so you need, if you want to do it, then we should think about, I'm trying to get back to my, we need to think about trying to harvest. If we're going to do it, if your AMH is low, I wouldn't wait too long. If your AMH is good, then we can't really use it to predict when you might have menopause. You could have it followed every couple of years. And the other thing that's interesting, this is very interesting. If your AMH is low today, It does not predict infertility today. But I don't have many girls who are trying to get pregnant today. Most of them I'm trying to counsel on what will this look like in 10 to 15 years. Is that sort of clear? Is it clear as mud or?
Yeah, no, that's really helpful. That's really helpful because I think there's lots of factors, and oftentimes I would encourage them to like consult with you guys in your clinic so that I don't tell them like incorrect information. But yeah, no, that I think that makes a lot of sense. I appreciate your explanation.
And I think maybe language that you can use is that's exactly what the Dora Clinic is for. And you could say, as Dr. Meacham or Megan talked to you about the Dora Clinic, because that's really the realistic checkpoint where
Yeah.
an actual REI doctor is going to say, I think this is like, yeah, if you want to, we should do it now, or we can do it, but we probably will only get 4 eggs and we need 8 or 10 to make a baby.
Right. All right. Thank you.
That Dora Clinic is a safety net for me too. I just hate that. What keeps me up at night is that a survivor will say, I wish I had known. I wish I had known I needed to do something. Okay, let's see. We're almost done, guys. So, okay. So did I do this already? I don't think so. So for girls, we have Dora Clinic, and that is where they can get specific information about egg harvest after treatment. And for boys, we offer semen analysis. If they want to do it earlier, every once in a while, I've had somebody before the age of 18. I always like that age of 18 because they can make the decisions, and as opposed to their dad. I mean, actually, if a dad wants a boy to have a semen analysis, he doesn't want to do it. I don't see how it's going to happen, but anyway, so it's nice to be able to communicate with them when they are making the decision. So we offer it at age 18 at that male health talk. If a patient chooses to do semen analysis while they're still an AFLAC patient, our team can coordinate it. Like we send in the orders. We can also provide interpretation for them, like given the level of sperm production, you can probably use it for intrauterine insemination, which is like $1,000, or you're going to have to use in vitro fertilization, which is like, we can add interpretation around their sperm count. In addition, we have asked Cure, and Cure Childhood Cancer will cover the cost for post-treatment semen analysis. It's not a huge amount of money. It's like $150, but still for some patients, that's a lot of money. So if they do it before transition, then we can, those are the things that are available to them. But I will say a lot of people by age 21 are not ready to do that. This is when I wish we could follow patients until they were at least 25, because I think the difference between a 25-year-old wanting fertility status assessment and a 20-year-old is hugely different. Caveat. So this is important if you're involved in counseling patients. Sperm production can recover up to 5 years post-treatment. So I just had a father and son want to know about fertility status. He's only a year off therapy. And I'm usually not having any of these discussions until you're 2 years off there, because that's when you come to Survivor. But he's like a little bit older. He's like 19. And I sort of had to say, at 1 year off therapy, I don't know that I would do it, because I think it's almost too early. If his count's good, great. But if his count's not good, then I think before I would put too much weight into it, I'd want to retest in 2 to 3 years off therapy, maybe even waiting for up to 5 years. So I think that's important to tell folks. Other helpful tools in talking with patients that you guys probably know this, but we have a Children's Healthcare of Atlanta Fertility Preservation website. It's got the who, what, when, where, and how of all the different fertility preservation interventions. And remember that aflacfertility@choa.org. You can email me directly. You can email there, and somebody will be there to answer any questions you might have about reproductive health. I'm happy to take any questions. Yeah, that's a good question. So actually, when we calculate the cyclophosphamide equivalent dose for bone marrow preps, they tend to be low. It's like 3,000 or 3 grams per meter squared to 4 grams per meter squared. So it's not the absolute dose. It's something about the intensity with which it's delivered. Having said that, even in some of the reduced PrEP regimens that we just put out a paper, but it had limited number of patients. But even with the reduced intensity PrEPs, we're still seeing AMHs that are undetectable. We don't have good semen parameters because we just haven't been able to get males to go for semen analysis. Other thing I would say about that is hydroxyurea is known to impair spermatogenesis, and it causes diminished ovarian reserve. So in general, for most sometimes I'll get like a thalassemia patient that gets like a whiff of TBI, like 200 centigrade. And they still seem to have pretty low AMHs. So I don't think we have a lot of good data on that. But BMT, and that's why BMT in general, even reduced intensity, is in the high risk category.
Thank you.
You're welcome. Thanks for the great questions. Bye, everybody.
All right, thank you.
You bet.
Bye.